Good afternoon, family. Welcome to Rhythm Unplugged. I'm here in Nairobi at AfriSTEMI, which is an annual congress celebrating 10 years this year. I'm very fortunate to have this time with people I call friends now, but we in business of healthcare delivery. As you know, I'm South African, where health issue is huge, and our health issue is very similar to USA, because if you have money, you're okay. If you don't, you're screwed. So I have here AJ, part of the GCC Global Cardiovascular Collaborative. He's going to tell us about himself, what he does. And I have an esteemed colleague here from Atlanta. Oh, Houston, yes. She was with us at the CASA, which is a cardiovascular rhythm management body in South Africa. She gave us a couple of talks, so hopefully we'll see her soon. So this is Eje, original from US, but it's got roots embedded here in Africa, particularly Nigeria. So we're going to talk about what we often talk about, which is health delivery, and enlightening people about what we do. AJ, let's start with you, man.
Kick it off. So you're the esteemed colleague. I'm just the colleague. First of all, I do want to thank you for having us, and I do agree. It's been great to get to know you over the past few years, and gladly call you a friend. So thank you for taking the time to sit down, and also thanks for being part of the documentary we're working on. So so as he said, my name is AJ Hale. I I'm employed by a family called Dennis and Jane Reese. They have the Dennis and Jane Reese Foundation, and they are incredibly kind and caring people who have allowed me the opportunity to work with Ijeoma to help build the Global Cardiovascular Collaborative, which is a platform for organizations in the nonprofit space looking to build cardiovascular capacity, looking to educate our friends around the world that need specialty services and education, as well as bring supplies. I think a reoccurring theme you hear a lot is, you should, what do you feed a man a fish? You give a man a fish, he eats for a day. You teach a man a fish, he eats for a lifetime. But I think Trevor Noah said it best, is you also should probably give them a fishing pole, because you're not going to. So I think that we're in the business of fishing poles and educating how to fish.
Yeah. You've traveled everywhere, or nearly everywhere, in Africa and probably other low and middle income continents. I don't know how much you know about South Africa, because this is particular for the South Africans. Where do you see yourself helping? I know how you can help, because the way I look at it, 14% of the people in South Africa have access to healthcare, and great healthcare at that. But the other 85% of people, there's a big bottleneck in terms of accessing this. And having said that, this is a story I never even shared with EG. 2004, when I started my cardiology training, I had this guy who came from Nigeria. He had a temporary pacing wire through his groin that'd been sitting there for 6 months. And he came to a public hospital at Ekeruo, where I was training. And the sad part of it, besides that he had this temporary pacing wire, which is completely dependent, could dislodge anytime and he could die, he was one of the lucky ones. And I asked him why, and he was happy. And he said, look, I'm happy to be here. A lot of people cannot be here. And I said, I was in the military. I was able to save some money. And I said, and that's the best you can get from the system. You serve in the military for whatever period of time. You can't afford a pacemaker. You have to do all those things. That's when, for me, the penny dropped, and said, look, obviously still had to pay, because he's a foreigner in South Africa. It was in the government hospital. And he was able to get his dual chamber pacemaker that maybe at the time in South African rands, maybe 25,000 rands or something. But it took him 6 months. And he was a lucky one. And he's a lucky one. So your job, it's important and it's big. So piggybacking on that, what would you think South Africans need from someone like you? How could you help us? Oh, you first. I mean, you
Me
still,
first.
yeah,
Okay.
yeah, with this collaborative.
It's very interesting you brought this up, because I think I'm ignorant of the context in South Africa. I was able to join as well for CASA, and I had a fantastic time, but it was also in Joburg and Sandton, and it's very isolated view of it. And most of what I know about South Africa is from books and Trevor Noah and things like this, right? So I I didn't realize the gap was that big, to be honest, of like 84% not having access to quality care, because I always kind of envisioned South Africa as a place. I know you're one of the most experienced people in the world when it comes to electrophysiology. We have many good physicians that come out of here. South Africa had the first heart transplant, right? Like, so in my mind, it's this incredible place that has obviously its problems, but I didn't realize the gap was that big. And after this conversation today, we'd love to come and help. Obviously, 84% is better than many of the programs we work with, where it's probably closer to like the top 1%, the top 5% get the care that they need, and everyone else suffers and waits and possibly waits to die. So, but I think there's still a massive gap, as you said. There's, I don't know how many millions of people, hundreds of
about
millions?
65 million people at the moment. Yeah.
Oh, 65 million people. I mean, that's so many people without opportunity, and I think that we would love to help with getting them involved in device reprocessing, which we can talk on later, or
use catheters,
which is common in the U.S. And Ijeoma, being the physician, can talk more about that. But I think there's a lot of opportunity, and I think part of that is demystifying what we do and removing the stigma of using reprocessed or using the same thing over and over again. As maybe I'll take this from you, this opportunity, but as Ijeoma always says, it's like buying a car.
I wanted to say that actually to bring her in. Buying.
Tell us about the car thing. Maybe
No.
No. You there? You
don't have to.
come. So once again, this is Eje. She's an electrophysiologist in Texas. She's very passionate about health and healthcare matters for Africa, and I'm assuming other continents and part of the world, where she gives her time away from her family, from things she likes doing. And I ask her a question: why does she do it? She feels that she's been very fortunate, and in that she's giving back. So Eje, you've already started helping us in South Africa. You gave us wonderful talks, and we are a country with a painful part. So are other countries, but I can only speak about South Africa. We are very fortunate to have you in CASA to speak for two reasons. One, you're Black. We had never had a Black person as part of CASA coming to talk to us, so that was wonderful. And secondly, you're female. We never had a female, as far as I can recollect, coming to talk to us. You've already paved the way of many other young Black colored people.
Wow.
Oh, that term colored again.
Yeah,
might come
people
back
of
to
color.
haunt me.
Yeah.
South
I mean,
African issues. Just to
That
digress
is
a little
true.
bit, that's been a big issue with one of our singers. What's her name?
Tyler.
Tyler. She's a two-time Grammy winner,
Yeah.
color.
Yeah.
But anyway, people of color. So when they look at you, I know probably it doesn't mean a lot because you've always been Black, right? So you don't know. But for you coming to South Africa, that was great. But
Oh, that's
beyond
awesome.
color and gender, there's more to it, much more to it. How do you see yourself helping us? Because we need help. 84% of the people don't have access to health as soon as they need it.
That's that statistic blows the mind. But it's so interesting though. So I'm coming from, if you think about the West, the United States, right, where everybody's supposed to have some access to healthcare and insurance and all of these things, and we still talk about health equity and or inequity rather, that comes about as a result of other social determinants of health, but it's still apparent, right? So this is not, it goes to show you truly that this is not just a low to middle income country issue, right? It's something that we really do have to address on a very fundamental level, right? Going with quotations, Martin Luther King did state, that of all the inequities in the world, inequities in health seem to be the most unjust and the most inhumane, right? And so when you think about that, why shouldn't we as physicians who are, who take an oath to help people, why shouldn't we take that on as a challenge? And a lot of times people say, okay, you know what, just don't talk about the politics of it. Don't talk about, just put your head down and deal with the issue that comes to mind. But you have to talk about the politics of it. You have to talk about the social part of it, because without that, then you cannot have meaningful change on a grand scale, right?
I like that part, politics, because people often say separate politics or even church with health issues, but it's inseparable. Right?
It
yeah,
is.
yeah, because politics is part of it, and
Yeah.
because most of this government, including my government, if they had the will politically, they could do something to reduce the number of people who cannot access health and increase their health capacity. So politics is always part of it.
And I will say this, right? I do agree that politics shouldn't be part of it, but I agree in the opposite way, where no matter what side of the aisle you are, we should agree on these basic things.
Then that's not politics anymore.
And
that's
then it's
just
not politics.
That's just morality, right?
That's morality. That's just life, right? But somehow or the other, we have politicized it. And I say we as in the royal we have politicized it. So we have no choice. Us as physicians have no choice but to get into politics because it has been politicized, right? Because remember, I remember when during COVID, we were talking about people wearing masks, and all of a sudden it became, if you wore a mask, then you belong to this person. If you don't wear a mask, you're in this camp. And it's like, shouldn't we all be in the camp of saving life? Why has this become politicized? And so, us getting into politics is not because we want to, it's because that's the world that we live in now.
So talking about politics, I mean, you travel extensively to many other parts of the world, but in particular Nigeria. I like to piggyback on that, South Africa. So how do you envisage in 5-10 years with GCC AJ engaging the politics? Because at the end of the day, is the willingness of the government to do something. Because AJ was talking about reconditioned pacemakers. They'll find every loophole in the system to say, well, we can't bring this here because 1% of people might have major issues with this, forgetting that 99% of these people will survive, right? So how do you engage government, or how do you see yourself in Nigeria and in particular South Africa helping us to engage the government on these issues?
I do have to commend, Dr. Crawford. He's been doing this work for many years, like more than 10 years, right? Where he was told about this problem, and, he's originally from Poland, or him and his family are from Poland. And so he's very aware of inequities in health, and, he dedicated himself to figuring out, okay, how can we take that first step to legitimizing this, right? And he took the time to make sure that the FDA was involved, to get a process approved, to help get funding, so that we can do this trial that was able to show data that people, so now once you have data, you can't argue with that, right? Because, no matter what you say, at the end of the day, something has been done that has nothing to do, that was blinded, that has nothing to do with who put it in, who didn't put it in. You have an institution behind it that supported it, the University of Michigan, and we're able to show, hey, there is no difference between these two arms. Patients who got new devices that the trial had to buy, right? So the patients that got new devices and the patients who got reprocessed devices, there were no differences, right? So that's a big first step.
Okay, talk to on that. Please talk to the South Africans and the Nigerians, a person walking the streets, and say, look, man, we've got to. You spoke earlier on another program where 2 emergencies in electrophysiology is when the heart goes very fast or when it goes very slow. So are there a grandma, 85-year-old, or a young mother, 60, and has a heart block but doesn't have the money? Is it safe for that person in 2026 to get a reconditioned pacemaker or use?
Absolutely.
Absolutely. So the anxiety and the concern has been
assuaged a little bit, yes. So basically, I mean,
unnecessary for these particular patients.
Right. And remember, there's testing. I mean, it's not as if you're taking a device wiping it on your body and just putting it in, right? There's a process.
That's important for them to know, right?
There's a process that it goes through. So think about it, with the car situation. Think about you buying, a used car. And let's say you're buying in the US, like Toyotas and Hondas, right? They would have
Prius.
So they will have these programs called it's a certified Honda, certified Toyota, right? And basically what that meant is they had taken the used one off of the market and they have run it through and replaced all the spark plugs and, changed the oil and reprocessed like everything that needed to be replaced. And then they put it out there. So the only difference was that, this is something that somebody has used before, but they've kind of upgraded everything to make it like, top notch.
Oh.
That's pretty much what they've done with these, reprocessed devices, where you have checked the device, made sure that the device is working well. You have, sterilized the header, which is basically where
and there's been a trial.
And there's been a trial.
So you're not the first person to get this, basically.
Exactly.
If you speak to that.
Yeah.
I just want AJ to come in here. So South Africa, because of religious backgrounds, you've got huge Christian societies, you've got large Muslim community, you've got atheists like me. We know that it does play a role. So how do you solve this issue where someone might have certain religious values that this thing has been on someone else and now has to be put on me? I'll give you an example. For instance, if you give someone a pig's valve that will save their lives, there are other people who will not take it. Like a Jehovah's Witness, if you take the blood out, it cannot come back to me. Are these issues that you've thought about? So when you sell these life-saving, cost-effective devices, have you thought about that?
Yeah,
religion is a big thing.
And just to clarify, when you say sell, we don't actually
sell.
sell.
Sorry.
Yeah.
Sell the idea.
Sell the idea.
Because these are donated. It's interesting you say that because we've been to many countries and we have had these conversations at various levels with patients, with physicians, sometimes with governments, and I'm happy to talk on that later about like how you can work with governments on some of those things. But in Ethiopia, for example, there is a lot of resistance to that, and it's been a difficult process to convince folks that something that was in somebody who might have passed away, because sometimes these devices were right. We can't secure that kind of.
Well, someone maybe passed because of motor vehicle accident. Nothing to do.
No, not because of the device.
Yeah.
In America, we put devices in 95-year-old people that are
with 2 years to live
on death's door, and the irony that these devices too are often the ones sold in Africa tend to have less battery, not across the board, but you end up, a lot of different markets have an inferior device or an older model, and these are the newer devices, the extended battery life devices, so some of them will actually have longer longevity than the new devices that you can actually buy in Africa. But as far as addressing that, I don't have a good answer for you. I think that it's education, it's reassurance, it's giving people the option and saying, like, listen, you can get a new device. Here's what it costs. It costs, last time I checked in Benin Republic, $3,000. In Nigeria, it's about $1,500 to $1,000 for a system, right? Or you can get this device for free, and then you maybe pay for the surgery. Maybe you pay for the leads that connect to the device to the heart itself, and it costs you a total of $600 versus $2,000 to $3,500. But you give them the option to think about it, and if they make the decision, that's ultimately their decision. But you have to give them the option.
But it's fine. I'll come back to you. It's important to put to a patient out there that not only that it's going to give them 9 years, let's say 9 years. In that 9 years, they may get a better job. They might get a degree. They might be able to go elsewhere in the world and be able to make money rather than dying now, right? Because if you don't have it, you might die, right? If you really need a pacemaker. So it's something that we have to discuss with the patients. And so it is life-changing, but people still have this resistance. So coming to you, I mean, the physical part of it, of implanting these devices, an average South African doctor who finishes training knows how to implant basic pacemakers, but not for heart failure. So in the near future, do you see yourself maybe rendering those services where in private sector in SA we're okay, but in public sector it's an issue where we have this bottleneck. If you need a pacemaker for sick-sinus syndrome, you may not get it because it's not life-threatening. So that's where I would like in the future to have someone like you coming to help. Even if you told me that sometimes you go to Nigeria and put 50% of the annual pacemaker implants, obviously the industry may not like that. Not his industry is a different industry altogether. But do you think you can do that in SA?
Of course. Like, because this is the thing, and it's not really, like, I would say I'm not really interested in just going and doing a whole bunch of cases and leaving. I am truly, dedicated to the idea of skill sharing and training.
Oh yeah, that's part of it in government sector.
Yeah,
because
exactly.
That's where doctors get trained.
And that is a necessary part of it. And as long as there is that,
Giving them a fishing pond. What was it?
Yes,
give them a fishing pole.
yeah.
As well.
So basically, giving the fishing pole, giving them the instruction on how to, so that they become more proficient in doing it themselves. I think that would be an amazing thing to do.
Yeah.
Because, and this is the way that we've actually tried to, when we talk to folks in industry who get upset with us when we do this, right? We try to tell them, look, and I use a lot of idioms, right? So it's like, look, a rising tide will raise all ships, right? So let's take, for example, one of the physicians who learned from us, Dr. Edafe, in Nigeria, right? So prior to us coming, he was putting in pacemakers, but even he would say not very well. Like, in times when he would do it, he would just be like,
Is that day to day I have to do this procedure?
Am I going to have to do this again? Or, getting access might have been an issue. And don't talk about putting in a CS lead. Like, I remember the first time he saw us put in a CS lead and it just went in. He said, "What is this?" Because it took him, is this, like, teach me, because I struggle with this. So, and you just put it in. And, it was funny because we put in the lead. And we say, okay, this is how you do it. We put it in. He said, just leave it there. And we're like, no. And we took it out. And we said, okay, now your turn.
How you do it?
And he said, what did you do? Like, it's going to take us 6 hours. And it's like, no.
Hold on a second.
What?
You need to tell us about the CS lead and heart failure and pacemaker just in a short while
So,
after that.
yes. So,
because that's important for training.
No, yeah, for sure. And so, but now he has become one of the most, he has become the most experienced and prolific implanter in Nigeria, right?
Well done.
And he's not just implanting devices that get donated. He's now implanting devices from industry and putting in a lot of BiVs, right? CRTs with, cardiac resynchronization, right? He's putting in those devices that they otherwise would not have been able to.
So the industry probably was short-sighted. They were just looking at you taking away 2-3 pacemakers from us.
Yes.
Not realizing that if you increase the awareness of what you can do, they will also benefit.
Increase the awareness, increase the number of people, right? Because also so he's putting in CRTs now. You have a patient who has this problem, and you talk to them. So if they have heart failure, and then they have a conduction abnormality, most commonly left bundle branch block, which is basically an EKG abnormality that makes it so that your heart doesn't beat in synchrony, right? So instead of your heart walls squeezing like this, they kind of squeeze like this, where they're not really effective, right? So it's not effective squeezing. And so by you putting in that device, you can actually make the heart resynchronize and make it squeeze together, right? So you have somebody who has that problem. Now, because he's put in a device in somebody who might have that problem, that person feels better. That person tells their friend, for right or for wrong, they say, I used to feel like you.
Yeah.
But now they put in this device, I'm a new man.
Yeah.
Right?
Yeah.
The friend comes over. Yeah. You help that one. Like, it helps raise awareness. The physicians are more aware. They're looking for patients.
It's a win-win situation.
The number of patients who get it done. Yeah. It's definitely a win-win. So, yeah.
All right. So
Sorry.
Yeah.
One thing I'd like to say is we talk about what we can do in our role, and I think that the industry in general tends to turn a blind eye to a lot of what happens in Africa because it's not profitable to them,
Yes.
right? And as a result, you end up with
Please say that
distributors.
again. Please say that again.
It's not profitable, so they don't. I don't want to say they don't care, but they don't care, right? Like it just. And at the end of the day, the people who are working on the ground for them are fantastic folks. We work hard with many of them. But ultimately, they still have to feed their families, and they are held to an account where they have to focus on the short term, right? So you can't really blame them when they see one pacemaker maybe that they could have gotten possibly if this family had sold their car to buy a device. Comes out of their pocket because they get a free device instead, and this family is now not financially ruined. But to them, that's an opportunity that they missed out on, right? It's our job as people who work in the West to have resources and connections to then advocate towards companies to be better actors in these countries and say, listen, like stop holding your people to short-sighted goals.
Yeah.
Appropriately cover their time and their pay so they're not focusing on this week or this quarter, but they're focusing on 5 years, right? So advocate on their behalf because we do have the power, we do have the platform, and I mean this is what you're doing now, right?
Yeah.
It's like leveraging your platform. We need to turn
Increasing
to
our awareness. Yeah.
And not
Exactly.
just that, but also, talking about the advocacy piece, and the government piece. I think that folks that are outside the West underestimate the effect that government has on the advancement of health and healthcare, right? So they think about, for instance, in the United States, you think about the U.S. being a capitalist country. But if not for Medicare, right, which is a government-sponsored, insurance program for patients who are older than 65 years old, if not for Medicare dollars, a lot of Medicare and Medicaid, the Medicaid is government sponsored for very poor people. Right now, there are situations where Medicaid is getting shut down and hospitals are closing, right? So if not for Medicare and Medicaid, those two federal programs, which by any other system would be called socialist, right?
Yes.
If not for those two programs, healthcare in the United States, we might be talking about the same thing, because private insurance does not pay for everything.
Yeah.
Right, it's prohibitive. It's cost prohibitive for sure.
Yeah.
So that is definitely something that we need to talk to governments about and basically say, hey, there are certain things that are necessary. If somebody has an MI that is an ST elevation MI that
Heart
needs a
attack, you
stent,
mean.
a heart attack, exactly. We need to put in a stent. If somebody has heart block, we need to put in a pacemaker.
It's just as important.
It is just as important. So there are certain conditions that we have to have covered by a government healthcare scheme, period.
Thank you. I'm just digressing a little bit, but I think it's necessary. So I love football, soccer. I know you call it football.
I appreciate
Soccer.
that.
So there's always this thing about who's the best soccer player ever. Is it Pele? Is Maradona in the newer generations? And growing up, and to be honest, I always said Pele, probably because he was black. You gravitate to that. We're talking about politics now. But as I grew older and coming from South Africa, I realized that we touched on it earlier on, where you cannot separate politics and maybe religion to our social ills. And I gravitate towards Maradona as the best player ever. Why? Because he spoke about social issues. When you talk about social issues, for me, you become more than just a player or someone important. Why am I talking about this? I'm South African, right? I've got Eje, and to a lot of South Africans, I mean, I travel quite a bit, and it's quite embarrassing when you go there and people talk about real things back home. Xenophobia, right? So I'm a doctor. I can just bury my head in the sand and talk about medicine, but here I am now in this platform with two Americans, one white, one black, that, it's a thing where if I have to invite someone like Egypt to my country, maybe her husband, her kids, I'm like, shit, they might kill my mom back in South Africa, these savages. And we have savages, right? So these are the issues that we have in South Africa that we still have to debunk, because some South Africans say, oh, all Nigerians are drug dealers, right? all Nigerians are like this. You know, it started off nicely with soccer, with music, and this and that, but it's becoming a recurring pain in our society. And these are the things that I feel as a doctor, I'm not just going to talk about health only. It's politics and increasing awareness that people are people. We've got evil people, we've got good people. You can't just wrap them in one and say, well, EG is a rapist or EG is here to take I don't know, my money or rob me, because all Nigerians are like this. And that's just a fabrication. But why am I talking about that is now I've got him. He's a white guy. If he goes to South Africa, no one will ever say he's a foreigner. He might have an accent as he has, but those are the social ills of our community.
Yeah.
And they're painful to talk about. But I always find that if you talk about these things, okay. So right now, last year it was national news in Cape Town, one of the most beautiful cities, gentrification, whereby basically means that rich people buy better land, better housing, which means that people who can't afford get displaced. You know, in your situation, correct me if I'm wrong, you had Manhattan, so those who couldn't live in Manhattan then would go to Brooklyn, and it means people from Brooklyn have to go somewhere else. So, and what is happening in South Africa at the moment, lots of Germans, I'm told, I don't have the statistics, are buying these houses, and I was like, oh, the Germans are buying all the houses. But if AJ was German, they wouldn't have a problem with him, but they would have a problem with Eje just because you're black. So those are social ills that I just wish at some point the government will talk about it. It's my responsibility as a host for this program that racism, tribalism, xenophobia is part of health issues. You know, this hatred that we have for certain people, these stereotypes we have for certain people, stereotype for gender need to be talked about. You guys don't have to make a comment if you don't want to, but if you want to, that would be great.
I would say, like, you know, that was one thing, you know, that came out of the COVID era in the United States, where, you know, even though we try to forget it now because there's been kind of a, you know, reverse, but, you know, there was a, you know, a real movement to call things by name. Right? So when you talk about social determinants of health, you're talking about things in your environment that affect your health, right? And so one of the things that was there, they would say race initially, right? And then during the COVID era, when we were going through this whole thing of, okay, no, we need to say the thing, you know, because even though we were saying race, we knew it wasn't just race. You know, it was the effect of race or racism that was causing it, right? And, you know, we cannot say that racism and sexism does not have a role in health outcomes, because we know it does, right? You know, there are, and I'll speak, you know, to in the United States, right, where folks will come in and somebody comes in with pain, but if they are a black person or if they are Hispanic, they'll say, oh, you're exaggerating. Versus if you're a white person, they would say, oh, okay, that's valid, right? And I've seen this in action, right? Or if you're a woman, like we mentioned, right? Where if you're a woman, for me, if I'm treating a woman and they say she has anxiety, I will say, you know what? Until I've ruled out everything,
Show me the ECG at least.
show me the EKG during these episodes of anxiety. Show me the EKG. Show me what is going on. Tell me what's going on. I have a really detailed, really detailed history and physical before I say, okay, this might be anxiety.
Yeah.
But this takes, and that workup will take up to 6 months, right? So these are things that we should like.
And by the way, this is education to the doctors. You know, what you're talking about right now.
I mean, and you know, we all need to examine our prejudices.
Yes.
Right? Because there are sometimes, unfortunately, you know, there are these words that came out of COVID that were great. Implicit bias is one of them, right? Where you have this bias that you don't even know that you have.
You start living now.
And it's okay to just sit back and recognize that you might have that bias, but educate yourself and, you know, try to make sure that it doesn't affect how you treat a patient.
Yeah, but before, I'd like AJ to come in here, but also in South Africa, we're so diverse, even when it comes to politics. so you'll have the fundamental view of a white person by black people, so where some black people will think most white people are evil, they are racist, and so it's nice to be here today because I've got AJ. He doesn't have to be traveling and crisscrossing the world. He's from US. He's white. He's young. He's a man. He's at the apex of the food chain, but he's doing this, right? So it is important to acknowledge these things, these stereotypes. So I'm very grateful, that you don't have to, like Ishi, she doesn't have to, but you also don't have to do what you do, but you do what you do. And who benefits most in this? Are brown and black people or people of color, whatever you want to. So I'm very grateful to have someone like you who pushes forward in countries like mine, where there's a lot of prejudice from one side to the other side, from gender to color and everything. So thank you. Do you want to say something? This is
well, no, I
this is a simple podcast.
Really quick, you did talk about, how it was different for people like me, like in South Africa, right? I live in Kenya now, right? And I, without a doubt, have so much privilege walking around this country, and it's a result of systems that were built. They were intentionally constructed. South Africa, from my knowledge, has one of the most designed forms.
It's the best prototype ever.
Yeah, they brought in specialists from Jim Crow South to help build a better racist system, and those systems still pervade, right? And then when you look at xenophobia, when you look at racism, ultimately you look at who is shining the light on them, right? So we're benefiting from systems of this. We're protected by systems by focusing on Nigerians who are in South Africa. Once again, not my country. I don't have all the context, so please don't cancel me. But by focusing on Nigerians and focusing on Western Africans and other Africans in South Africa and saying they're the problem, you're keeping the light off of the real people who are taking the money, who are creating systems and benefiting themselves.
And they want you to do that.
It's intentional.
Yeah.
It's intentional.
We see with Jeffrey Epstein files, if it's true that they're trying to change.
I'm not trying to disappear.
I'm trying to say, so it's important that you raise that issue, that people don't see themselves as a problem, but they are a problem themselves, because there comes a time where you need to ask yourself, why are you with these people? Why do you believe a certain politician, and you just do as they tell you, or people, your local commander, because if you look at places like Rwanda, it just largely started by a radio DJ, where you influence people on baseless things. All right, so I know but
you say largely started, but I agree that was the spark, right? But the kindling was laid way before that by colonization. So we have to acknowledge these systems that have already been put in place. And when we talk about health equity in America, right? So I grew up in the Ozarks. We wasn't the most... it was not you might have seen the TV show. It's not the most diverse area in the world. And it still isn't when you go back there. There's a few minorities, but it's still mainly just white people everywhere, right? Then I traveled to St. Louis, and that was like my first real... I went to school in Columbia, it's a big thing. But anyway, St. Louis, and you see these like red lines. Like we talk about redlining in America, it's intentional systems to keep black people from integrating with white society. And that is still pervasive. There is still hard lines where you will cross over. And you talked about Ferguson, Missouri. Remember when...
I remember that.
Brown, correct? I think it was Ferguson, Missouri. Like when that was a huge thing. That spark lit off kindling that was laid years and decades and hundreds of years before. And I would end up being often the one to go and serve those communities, just because I'm not really worried about it. Like, it's fine. People are people. And I didn't grow up in a system that told me that these people are scary. So I never really thought about it as a bad thing. I just know don't necessarily stop at every stop sign. I don't know but other than that, like you go and like, you see the disparity in care in these rural hospitals, obviously, that address all populations, in these inner city hospitals that are horrific levels of care, and it's still pervasive today. America, one of the richest, wealthiest countries in the world. So it's sad, and you see it everywhere. But you say like, why? Like, you don't need to thank me for doing this. I love this, right? Like, why do I do this?
Well, I'm grateful. Nonetheless,
either way, like, it's for me. every day I work with like some of the greatest people in the world, some of the most hardworking. Either they're volunteers who are giving of their time and separating them away
Like
from
someone
their
like
family.
Crawford, for instance. I mean, like you
Like
mentioned,
Crawford,
EG.
like Ijeoma, who like
She doesn't have to be here.
Yeah, spends a lot of time, and I really appreciate your family for allowing you to come out and get
I
away so
appreciate my
often.
family
I also
too.
appreciate your
I
family
know.
on camera.
I
That she's
appreciate-
not going to be slaughtered in South Africa.
She'll be fine.
We're working on that. We're working on that. Yeah. No, we're free. Yeah, we speak freely.
Yeah,
I should say I also appreciate my wife for allowing me to travel the world as well, because
Thank
I
you.
without any
Big ups
I
to
would
her.
not be able to do that either. So
Yeah.
I
Just get me a
appreciate-
bottle of rum.
But yeah,
A sidekick, what do you do, sidekick? Rum. Tell us briefly about rum. We're not big in rum in South Africa.
oh, it's not a side gig. It's just a friend has a Rwandan rum company called called Amizi Spirits. No, we'll see if Rohan wants a commercial. But Rohan and Kara started a rum company in Rwanda. So if you're
So
interested,
guys,
I'm happy
yeah,
to tell
yeah.
you. About it. But no, all of that is to say that like I am incredibly privileged that I work every day with some of my best friends, and I get to work with people around the world that I get to call friends and make an impact in people's lives, and I get to see a tangible benefit. And I don't think a lot of people get to do that. So I don't really believe true altruism exists. I think that like people get value out of this. I get value. It fills my cup every single day, and I've never gotten tired since I quit my job in the industry and started doing this. There's not a single day. I'll be exhausted, but I'm never tired of it.
Well, I'm going to tell you
So-
one thing, real quick. When I first met you and her,
Yeah.
I don't really believe in energies, but when I met the two of you, I just want to be with you. Really, seriously. It's so
Hey.
impactful in my life. And I'm not
Well,
an
that's-
emotional person. I'm not at all. Not by but I mean, I just love you guys for what you do and how you come across. You don't put yourself in a pedestal. Hey, look at me. This is what I do. And I really wanted to do this because you're doing some great job. And it's nice to be acknowledged. Thank you very much.
you so
And for those folks at home wondering what
love
I
you too,
have
Brian.
here,
Yeah.
this bottle, only the Nigerians will know what this is, right? This is groundnuts. We call peanuts back home. This bottle actually, it was not decanted into this bottle. It comes with this bottle, but it makes sense, right? First you laugh at it like, why nuts in a water bottle? And then actually, you don't have to put a pack on it to keep it fresh. So this is great. This is for the folks back home. Think about it. You
love
might to go
That's
to
the ad
business
break
into
you have. Like most people have like ad plugs or like peanuts in a
I didn't know I had this intentionally because this
This
is my first
podcast is
experience
brought
with
to
this.
you by
Great.
peanuts in a bottle.
Yes. Thank you very much. Any parting words? I'm
No,
just
I
so
just
grateful for you
want to
guys.
say thank you so much for all that you do. I mean, speaking of physicians that we've met, informing the GCC, like when we're talking to different people and people already doing the work, like you have been doing this, for such a long time. You could be in Canada making millions of dollars right now, but you're not. You came back to South Africa and you are, living the life. And not just that, but you travel all around teaching people how to do what you do. So it's not like the things that we do is always like just great to see somebody who is also doing it, locally. So I just wanted to shine that light as well.
Oh, thank you very much. Don't make me cry, man. Okay.
I don't think I could say much more than that. I mean, I completely agree. I think you're doing incredible work. And I also love that, as you said, it doesn't stop at just being an educator in healthcare, but also an educator to the public, right? Like creating a platform, using this platform to reach out and give people an opportunity to learn what they might not have is incredible. So I love it. Thank you for giving us the time to sit here with you, and I hope to do it again soon. This was fun.
Hopefully.
Yeah.
Hopefully.
Hey, well,
we've got a
maybe
lot,
see you in-
lots to share.
Yeah.
I know at the beginning we said 15 minutes, but probably we've gone to 30, 35 minutes. if not more. Thank you very much, guys.
All right, thank you. Bye.
Cheers. That was good.